right.
Hello, I'm Catherine Stout, an instructor at Amarillo College, and I will be performing the newborn assessment today. Whenever you assess your baby, you want to look generally overall at the skin color. We're looking for any acrocyanosis, the blue hands and feet. Maybe we need to warm the baby up at this point. Looking for any central cyanosis down through the nose and the mouth area. This is a late sign respiratory distress. You're going to look for any jaundice from head to toe, any yellow discoloration of the skin. You're also going to look for desquamation. This is the dry, cracked, peeling skin that the term baby might have. And as you can tell on her hands, she's got that dry, cracked, peely skin. Then after that, you definitely want to use a systematic approach whenever you complete your newborn assessment. While you are doing your assessment, you want to listen for the cry. Is her cry lusty, monotone? Is she having any grunting, any respiratory distress? So with that being said, let's just go ahead and start at the head. And you want to pick up your baby's head here. And for her sake, I'm not going to do that because we want her to participate here. You're going to feel the anterior fontanelle up here. We want it to be flat and soft. You're going to check to make sure that it is not sunken, which is a sign of dehydration. And make sure that it is not bulging, which is a sign of increased intracranial pressure. So her anterior fontanelle is flat and soft. Then you're going to come back here to the posterior fontanelle, and hers is flat and soft back here too. As you're assessing these, you're going to run your fingers down through the suture lines, back around. You want to see if they are approximated, widened, or overlapping. Your baby that has overlapping sutures is going to be the baby that was born vaginally, maybe down in the birth canal for a long period of time. Her suture lines are approximated. She was a C-section baby, and she was never engaged down into the birth canal. You're going to also look for any fetal scalp electrode marks. These are going to be the bloody areas or scabbed over areas throughout the head where that fetal scalp electrode was placed. You're also going to look for cephalohematoma. This is going to be a hematoma to one side of the head. It does not cross the suture lines, and it's due to a vacuum extraction or a quick precipitous delivery. You're going to check for caput. It's going to be the edema on the back side or the occipital area of the head. This crosses the suture lines, and usually this is due to the baby being down in the birth canal for a long period of time. With your caput, you also might see molding. This is that elongated shape of the head, or you might also know it as like a cone head. And since she was a C-section baby, her head is perfectly formed and no elongation of the head there. Then you're going to move down to the ears here. You want to make sure that they are developed correctly and formed correctly, and hers is. We're going to check for ear recoil, and she has good ear recoil. Then if this baby's ear cartilage is flat to the surface, or you don't have that nice pretty ridge, that might tell us that we have a preterm baby. And also, if this ear is maybe not developed correctly, we might suspect that there could be some kidney issues as well. We're going to check the top of the earlobe here, make sure it lines up with the eye. And it does. If this earlobe, the top of the ear is low set, that might tell us that we have Down syndrome. And hers is perfectly in line with her eye. We're also going to look at her eyes here Look at the sclera, make sure that there's not any drainage, any jaundice or redness of the eye. Sometimes if this baby might have an almond-shaped eye, this can indicate Down syndrome as well. Moving on down to the nose, and I apologize here, she's not really turning her head towards your way, but on the nose area, cheeks, face, we're going to look for any milia. That's the little white spots on the cheeks and nose. And then you're going to check for nasal patency. And how you do that is you occlude one side of the nary, look for flaring on the other side. And then you'll do it as well on this side, occlude it, look for flaring on that side. And then also you're going to look for any kind of red pigmentation anywhere on the face. Usually it's going to be on the eyelids. This is called stork bites. And she does have a little stork bite on her right eyelid. Then you're going to perform your mouth assessment. With a gloved finger, you are going to feel the gum line for any natal teeth or Epstein pearls. Top and bottom, you're going to check the hard and soft palate to make sure we don't have any deviations there. And we don't have any deviations. While my finger's there, we can check the suck reflex, and she has a really good suck reflex. Alright, moving on down to her clavicles, you're going to really palpate this clavicle here. Check for any crepitus. This would indicate that she has a broken clavicle. And those babies that have this broken clavicle or crepitus is usually due to shoulder dystocia at birth. You'll also notice if this baby does have a broken clavicle, they will have this arm guarded at all times. They won't have good range of motion. So you're definitely going to be watching your range of motion throughout your assessment as well. We're looking for any, we want to look for chest symmetry. She does have good chest symmetry. If you have your stethoscope, you will want to listen for your heart sounds. If you identify a murmur, you need to know the baby's age. If the baby is less than 24 hours of age, a murmur would be considered okay. If she's over 24 hours of age, then we might consider getting an echocardiogram to rule out any other heart conditions. We're also going to listen to lung sounds and bowel sounds. Then we'll go up to her nipples, make sure that her nipples are in line of each other. You're going to check breast tissue. This is part of your Ballard assessment. You're going to imagine how many dimes fit between those two fingers. Usually 3 to 4 is about a term baby. When you are checking that and you do get some discharge from that nipple, that is called witch's milk. That's due to the mom's hormones, and that is completely normal. While we have her laying here too, you're going to look, she has her vessels that are close to the skin. We do know that she'd be at risk for altered thermoregulation due to all of those vessels being superficial to the skin. Then we're going to go down to the umbilical stump, and of course her cord has already fallen off. If you have a fresh baby and have that cord in place, you would document it as a moist cord. A couple days out, it'd be documented as a dry cord. You're going to watch for any signs and symptoms of infection, any redness, drainage. And on her, since her cord's off, we're just looking for the signs and symptoms of infection, and she looks good. Although she does have a little bit of an umbilical hernia here where this cord is protruding. You definitely need to be able to verbalize that she does have 2 arteries and 1 vein, and you'll be able to visualize those in the clinical site. In the clinical site, you're going to also see your nurses perform brachial pulses and femoral pulses. So here's your brachial. If you find the nipple and come right down to the groin area, you'll be able to feel the femoral pulses. Then for the hip area, you're going to check the Ortolani maneuver. This is where you stabilize the greater trochanter and fan that leg out, checking for any hip click or hip dysplasia. And her hips are good. Then you'll perform your genital assessment. This is baby girl. We want to ensure that her labia majora is covering her labia minora and clitoris. That tells us that she's term. If her labia minora and clitoris was exposed, this would tell us that she's preterm. You're going to also look for any vaginal discharge. This would be called pseudomenstruation. It can be a pink to a red, even a white creamy color, and this is just due to the mom's hormones. If you have a boy baby, you're going to be assessing the scrotal sac. You're going to be checking for rugae. This is the bumpy area on the scrotal sac, and a little bit of pigmentation on that scrotal sac as well. That tells us that this baby is a term baby. A preterm baby, the scrotal sac is going to be more slick without that rugae. Then you're going to assess the penis. You're going to make sure that the urethral opening is at the center of the tip. If it's below the tip, that is called a hypospadias. If it's above the center of the tip, it's called an epispadias. Also, with the scrotal sac, you're going to check to make sure that the baby has 2 testes. You're going to palpate the 2 testes, make sure that they are descended down into the scrotal sac. While you're down there doing your genital assessment, you are going to check the anus. Is it visible? And is it patent? And the way we know that it's patent is if the baby is stooling. Then you're going to come down, make sure we have 10 fingers, 10 toes. You're going to check the bottom of the foot here. We are looking at the creases. If we have creases that are covering 2/3 or more of the foot, that tells us that the baby is term. If the baby's foot is slick, that tells us that the baby is more preterm. Alright, and then I'll come back and do reflexes in just a moment. So then we're going to roll her to her side very gently. We're going to look at the base of this neck for any pigmentation. You can have some stork bites on the back of the neck here. You're going to run your finger down the spinal column all the way down here. Check for a dimple when you're here. If you have a dimple, you want to make sure the skin is covering that dimpled area. We're also going to look for any dark pigmentation on the buttocks and shoulders here. That would be called Mongolian spots. This is going to be in your babies that are darker ethnicity. And she does not have any Mongolian spot here. While you're looking, you're also going to be looking for any lanugo. That's that fine downy hair down through the back area and the abdomen. And she does have a little bit of fine downy hair. Alright, so for your reflexes, you will of course perform the suck reflex that we already did. You can do the rooting reflex where you stroke the cheek, and once she turns towards your finger, that would be called rooting. You have the palmar reflex where she grasps your fingers, and she does it just like that. For your foot, we have the plantar reflex, and you just put your finger right under the toe area, and she curls her toes over your finger. Then we have the Babinski. It's the backwards J. So once you perform that backwards J, her toes flare out. Then you have the startle reflex, also called the Morrow. This is where you can bump the side of the bed, slam the door, or you can simply just pull up on the baby and gently drop her down, and they'll come up and make a C shape. One other reflex that we don't typically elicit in the clinical area, but you're going to see it in your book, it's called the stepping reflex. It's where you hold your baby up, put their feet to the surface, and they'll usually pull their feet up. And there she goes. All right. Part of your Ballard findings that you're going to perform, I've already performed a few, but you're going to start up here with your square window. That's where you pull this hand down. And if it falls flush with the arm or the skin, she's not really participating here, that's a more term baby. If her hand doesn't fall flush with the skin, that's preterm. The other one is going to be your scarf sign. Make sure the baby's flat to the surface. You're going to pull the arm across. We'll see here. You're going to find where that elbow lands. If it's nipple line to midline, that's a term baby. If the elbow lands past the midline, it's a preterm baby. Then you're going to do the arm recoil and leg recoil. There's several ways you can do this. Pull the arms above the head, hold for 5 seconds, pull down, and let go, and she recoils up. Same with the legs here. Pull the legs up, pull down, and let go, and she pulls her legs up. So she's got good recoil. A couple of other Ballard assessments that you'll perform is the heel to ear. Sometimes you kind of have to loosen them up. So pull this leg up here, make sure she's flat to the surface. Once she meets resistance, that's where your measurement will be. A term baby, that's about where the leg should land. Now a preterm baby, that foot will usually go all the way back to the ear there. They're very flexible. The other one that is very similar, again, the baby needs to be flat to the surface. You're going to pull the leg up till you meet resistance, pull the lower leg up till you meet resistance, and you're looking at this angle right here. As you can see, she has a 90-degree angle, so that means that she's term. If this angle goes any wider, that would tell us that she is more preterm. All right, that completes our newborn assessment for today. I hope you find this helpful in your clinical practice.